States, and I suppose this would apply to your countries as well, looking at what existing national guidance and protocols exist for assessing MCI and dementia in the general population, and whether those protocols and guidances are also adaptable or include provisions for people with neuroatypical conditions. And what we found is, in our studies in the States, is that little guidances, even looking internationally, contend with diverse populations, for example, dealing with language diversity, if you have a multicultural population in your country, ethnic backgrounds, if you have, again, a multi-ethnic population in your country, and pre-existing conditions such as neuroatypical conditions. And there's also a lack of information about modifying the common instruments that are used for the general populations, like the MoCA, MMSE, et cetera, other instruments that are usually used as screening devices for detection of early dementia in the processing of an assessment interview. So those kinds of things are challenges. And we also found from this work that most clinicians who examine people in the general population are not oriented toward assessing people with neuroatypical conditions or neurodivergent conditions, and are not trained to do so as well in their own professional backgrounds. So a lot of this is not covered in trainings in most protocols, and it can lead to mistaken diagnoses if the pre-existing conditions or the cognitive variations, for example, are not considered, or testing procedures are not adapted in that process. This is the report that came out. It's available on our website. The website is shown on the slide up there. It's quite an extensive report, about 120 pages or so, drawing upon experts from various fields dealing with neuroatypical conditions. And we assembled them through a very easy process, which I'll describe in a few minutes, and was undertaken both by the Lumine IDSC Foundation in the States and our National Task Group, which we are basically an advocacy organization on behalf of people with intellectual disabilities affected by dementia. And the group was charged with examining what barriers existed to effective screening and detection, and what, in terms of assessment of adults, whoops, we don't need to do that. That went up there too quickly. An assessment of adults with neuroatypical conditions, and identifying what special adaptations may be needed and employed in terms of recommending adaptations to the protocols. So what was the process? We started out with the discussion with our federal or national officials in the federal government who govern protocols and guidance for both payments and for assessing clinically people who have dementia, and determined that there was a lack of specificity dealing with neuroatypical conditions, which we abbreviated NAC, NAC for shortage. And they suggested that we undertake some kind of a query and provide guidance to them on this issue. We secured an expert panel made up of some senior individuals who represent different professions. We went through the various professional organizations and others by word of mouth in terms of securing them, and created a workable panel who could advise us. We also then followed up when the panel completed its report with a presentation to the federal council in Washington, an advisory council on national Alzheimer's plan. We have a national Alzheimer's plan in the United States. I'm lucky enough to sit on as a member on that panel and led the discussion on that report. So we reported to the panel so that we could incorporate in updates of the National Alzheimer's Plan provisions for inclusion of people with neuroatypical conditions. Quickly, I'm just going to go over 3 different barrier areas that we discovered. These are in our report, so if you do Google and get that, download the report, you'll find this in great detail. The recommended instruments are based on normative data, usually that are used with the general population, and have not been normed on people with atypical conditions. The information is usually lacking when instruments might not apply with adults with select neuroatypical conditions in terms of a warning for the clinician to be aware of this. Guidance is not given on the need for baseline and sequential applications of the measures when emerging cognitive decline overlays existing cognitive impairment. Instruments are not adapted for cultural or language factors to make them more familiar to adults with neuroatypical conditions who may be culturally different or language use different. And examinations by clinicians are generally unfamiliar with neuroatypical conditions, may lead to misunderstandings in what they are assessing. So then we move on to communication barriers. As you can imagine, there may be some difficulties in both drawing out information and providing information. Some adults may have various types of aphasia that would interfere with verbal functioning. Some adults with hearing impairments may not hear instructions, and those with cognitive limitations may not comprehend queries or instructions. Some adults may not respond in a typical manner or may react adversely to touch or requests for information, or lack the motor skills to complete certain performance tasks on the instruments that are used. Okay? Impediments may lead to clinician misjudging the adult's state of mind, or mistaking normal behaviors, what we call normal behaviors, as symptomatic of MCI or dementia. This may be typical of the person's repertoire of behaviors, and it's atypical in terms of dementia. And the clinician is not understanding adults with impaired speech and articulation issues. And lastly, the condition barriers. Clinicians may be unfamiliar with the inherent nature of a neuroatypical condition, which could lead to misunderstanding the neurological processes in play. Clinicians may be unaware of adults' degree of pre-existing cognitive disability and coincident conditions and immediate lived history of the individual, remote history of trauma expressed or unexpressed anxiety at the examination, and understanding of posed questions and or existing limits in expressive language, which all can misguide assessment. And then dealing with confounding symptoms and presentations by adults having multiple conditions. For example, a person who has Down syndrome and ASD, has autism, a person who may have cerebral palsy and a psychiatric disorder. These may impair assessment. And then some conditions may be linked to impairments that confound the flow of the assessment process. For example, hearing, vision, thought disorder, rigidity, concreteness, and manual dexterity. So this is, you can't read, I'm sure, but it's the table that came with the report, and it kind of does a cross-match of the conditions and some of the factors that are associated with trying to maintain balance in the assessment process. So I draw your attention to the report. It's also published in a journal called Alzheimer's and Dementia. You can draw upon it there if you go into the internet and Google the neuroatypical conditions report, and you'll see it popping up. The key points, basically, for guiding protocols. You know, we think one is adults with neuroatypical conditions face a variety of barriers to be accurately examined and having determinations made about them whether they have new or a new cognitive impairment. Most clinicians experience difficulties in discriminating current behavior and function from what was pre-existing in some conditions, particularly those that may include lifelong cognitive deficits as opposed to those may have acquired deficits in later life. Many of the conditions include problems with comprehension, oral communication, motor task performance impediments, recognition of assessment-related visuals, and comfort in testing situations. And for conditions with pre-existing cognitive issues, the use of standard dementia assessment measures is not indicated unless the measures are significantly adapted or specially designated. And then also for conditions with motor or sensory impairments, special adaptations related to compensating for the impairments are necessary to obtain valid scoring. Lastly, some of the conditions have definable risk for MCI or dementia and are backed by a significant field of study. Others are still beginning to be studied and present with varied expectations of risk of dementia and inherent factors affecting cognitive decline. Basically what that means is that some conditions have a long history of a relationship, for example, to Alzheimer's disease. Others may not have. To increase the accuracy rate of the assessments, practitioners should be aware of the nature of aging effects and interactions of these conditions, know the expectations of a cognitive decline, and risk of dementia and what type, and be familiar with testing adaptations that can facilitate the examination process to generate meaningful data. And lastly, not providing, and this again something particular to insurance schemes in the country, not providing reimbursement for assessment to adults with risk for a younger age onset dementia, not yet 65, for example, is a barrier to the effective and early detection among some adults, including those with some of the neuroatypical conditions. Okay, so lastly, the take-home points in terms of trying to make this change in your countries. One, working with governmental authorities or ministries to adapt advisories on testing to include accommodations and adaptations for people with neuroatypical conditions. Work with professional associations, medical, psychological, nursing, et cetera, to issue discipline-specific guidance or protocols for adapting assessment procedures. Work with national dementia associations to issue advisories on assessment and diagnosis of adults with neuroatypical conditions. And lastly, working potentially with national disability groups to issue advisories on assessment and diagnosis of adults with specific neuroatypical conditions. So, and the two publications are listed, shown on graphically on the right, and you can obtain them through the website that is shown up there. And then also just my contact information at the university if you need to get in touch with me about this. Thank you.
Thank you. Just hang on here, Matthew, for 2 short questions.
Okay.
Can you hear me? Great. So, Matthew, interesting, and thank you also for referring to all the information that you're shown so that we can read it afterwards. That is very valuable. I just want to know, could you quickly describe the most common BPSD symptoms with person with Down syndrome and dementia, just briefly?
Well, it's complexity. I mean, all of these conditions present with varied complexities of presentation, and it's hard to say that it's uniform across the conditions. I think clinicians have to be astute enough to understand sort of the inherent behavior that some people show. For example, with traumatic brain injury, there are some facets that show up commonly, but mostly they're individualized based on where the brain injury source is. With Down syndrome, you find a lot of variation as well. We know that one of the things that shows up with Down syndrome as an early marker of change in leading to the diagnosis of Alzheimer's is the change in personality. That's usually the first indication that something's happening. The person is no longer sort of an outgoing, emotional person. That is an indicator that there's a change, and it usually
more inbound.
In Down syndrome, well, not compared to the others, but that's in Down syndrome as opposed to the general population of other people, yes, as opposed to early memory loss, which is what you find in other conditions. That's one of the things you see there. But again, the report kind of covers in detail some of the key markers that you look for as a clinician for each of the conditions, and which conditions may lead to which form of dementia. And it's not all Alzheimer's disease, obviously. Down's is the one that's usually associated with Alzheimer's disease, but the other conditions vary, whether it's vascular dementia or frontotemporal, et cetera. So, and some do not show a high rate of dementia out of the norm of the population. Some show a high rate. Down syndrome is the one that shows about 60% of the individuals after age 60 have some kind of designatable Alzheimer's dementia symptoms. So,
right. Thank you very much.
What was the other question?
The other question was, let's see if I can phrase it for you. We talked earlier, before we entered here, about baseline and persons with IDD in comparison with normally developed adults. That could you, if possible, briefly, this is very hard, but could you elaborate a little bit about baseline and what that is? I saw it.
Oh, baseline. Oh, okay. I didn't catch the word. In people who have pre-existing conditions, oftentimes the behavior is particular to the condition and the person, as opposed to the general population where you don't see a person showing behavioral abnormalities prior to a decline that may be resulting from some type of dementia etiology, whether it's frontotemporal or Lewy body or et cetera. So it's good to have a baseline of functioning. Baseline means basically recording the functions, the behaviors of the person at their best, what we call a personal best performance. So with Down syndrome, you want to know how the person speaks, how they walk, how their fine motor skills, et cetera. And you record those in some manner. Now with these cameras that we have in our phones, it's easy to do that at home. And the standard measure, and you record it periodically over a sequence of time, maybe every 6 months, every year, depending on where you are in age. And the average age, for example, of recognizing an onset of dementia in a person with Down syndrome is at age 52. So if you start in the late 40s recording kind of baseline information, you'll have that to move up there. With other conditions, it may be later than that. So you collect information over time so that when you go to a clinician, the clinician can look at the previous functioning level, and compare that to what they're examining right now. And that way they can make the distinction between the dementia that may be coming up, the function, the performance of the expression of dementia, as opposed to the expression of the condition the person has, and then make the diagnosis of MCI or dementia based on that. So that's what the baseline covers.
Thank you. Very good. So thank you, Matthew. And let's move on and move the focus a little bit from detection to inclusion. So welcome, Karen, and your first presentation here today.
Thank you. Thanks very much, Karen. So, yes, intellectual disability and dementia, stand by me. So what I'm going to be talking about is research that's ongoing at the University of Stirling in Scotland at the moment. And this is in collaboration with a social care provider in Scotland and with Alzheimer Scotland. And we were due to start in 2020. Didn't happen, obvious reasons. We did manage to get started in 2021, and we're due for completion in 2023. But what I'll be talking about today, and perhaps most importantly, is the rationale for the study, why we're looking at this study in particular, and how we went about collecting data and some of our findings as well. So that's the plan for today. And the key purpose, as you see from the first slide, looking at couples who have an intellectual disability when one partner has a diagnosis of dementia. So you might think, well, actually, yeah, I've never thought about that before. And that seems to be the case for a lot of people because there isn't any evidence or any literature on that already. So that was one of the first things that we set to find out. We thought there wasn't anything, and turned out we were right. So what we aim to do in the study is to explore the day-to-day experiences of couples with intellectual disability and to identify the factors from their perspective, from their family's perspective, or support staff, if that's appropriate, how to support that relationship, how is that sustainable? And we know there are challenges in relationships where the couple don't have intellectual disability and one partner has dementia. So actually, what's the complexities that are around? What supports may already be there and what supports are needed in terms of maintaining that relationship and getting that insight. So that was really our starting point. And we know of the risk of increased dementia among people with intellectual disability, especially people with Down syndrome. We know the risk is much earlier and occurs in more people relative to the population of people with Down syndrome. But we also are celebrating the fact that people with intellectual disability are living longer. We're celebrating the fact that people are in relationships and getting married. So how does that tie together when we know of this increased risk as well? Now, the rationale for this study came from my previous research, which was looking at the implementation of non-drug supports with people who have intellectual disability and dementia. And I had a team of co-researchers with intellectual disability on that study. And while we were conducting that research, one of the co-researchers with intellectual disability had a diagnosis of dementia himself while we were actually doing that research. And we've talked about this a lot, and he knows I'm talking about it today, obviously. And at the time he said, well, what happens now? What happens? This is a married man with Down syndrome who has a diagnosis of dementia. And the quote here is one from Andrew. What if my behaviour to my wife changes? How will we cope? And that was really, really important to him. Long-term relationship and marriage. But also things like understanding and awareness of what it meant to have dementia. So the perception was that actually I've got this diagnosis now. Overnight, things will change. Tomorrow, I'll be the person that in my head is someone with dementia. And his perception of that was that things would shift immediately, instantly. So we need to think about how that diagnosis is shared, and that's, some of you might have heard me talk about that before. That's for another day. So that's certainly an important part of the process. So really important, and we keep talking about this, but Andrew was a catalyst for this study. So we went to the Dunhill Medical Trust, who have funded it. So that's really how we got to where we are today. The images, the photographs in here are, they're all actors. So any photographs you see on the screen are not people, they're not participants in the study. They're all actors who worked with me on a different study. And so they're not people with dementia. Some of the other images that I'll show you, we commissioned especially for the project. in terms of how we would support the focused conversations, as we call them, with couples who have intellectual disability. So we started off by doing a scoping review, just to make sure, because we didn't think there was anything, we couldn't find anything. So we did a scoping review just to see what else is out there in terms of supporting this population in relationships after a diagnosis of dementia. And that did confirm that there was no other study had taken place. But we found information, as you would expect, around couples with intellectual disability who didn't have dementia and were in relationships and marriages, and there was literature and evidence there and examples. And we also found evidence and literature of couples who didn't have an intellectual disability, where one partner had dementia. So much more common to find that kind of information. Although the data that was collected typically tended to come from the partner who didn't have dementia rather than the partner with dementia. So we were keen to kind of merge those pieces of research, but also to hear from as many people with ID and dementia as we could as well. So we also, we talked to family members and we talked to support staff, and as you might expect, sometimes found contradictory information, what the couple might want from their relationship, and actually to what a family member or a support worker thought might be best. So there wasn't always agreement there. But the most important part for us was to hear from the couples themselves. And in some cases, it was one partner. In a couple of the relationships, the partner with dementia had died. So it was just one partner. Now, it's quite a small sample size. We collected data from England and Scotland, but we're aware it is a small sample size. We also had very strict ethical criteria that we had to follow in terms of our population, our sample group, which is obviously very important. But also it's a difficult topic to talk about. For anybody, no less someone with intellectual disability. And of course, as I said, a couple of the partners had died. So there was all sorts of issues, and part of our ethical criteria was that if the partner had died, then there had to have been a considerable time frame between that happening. So it wasn't raw. It will always be raw, but it wasn't within a close time frame for the data collection. So there were a number of factors that we had to continue as well. So I'll say a little bit more about the focus conversations and how we did that. So we literally we printed off big A4 size posters, our pathway, our roadmap through the relationship. And we talked to couples about, always started positive. So we learned so much about the couple, about how their relationship started, about weddings. We've looked at wedding photo albums, celebrating weddings, things a couple like to do. Through that process, through the diagnosis, through telling people about having dementia, through having the diagnosis. For some this varied, obviously it was very individual, so for some couples it was now and the future, for other couples depending on their situation. We didn't always go into to future plans or hopes, or that was really important for some people. Not as easy to talk about, but we always started and finished on a positives about the relationships, the good things to celebrate. And what I've done is I've overlaid some of the images that we commissioned to guide those conversations on the top here. Now, it was never as cluttered as this when we were actually having the conversations with individuals. This is purely for presentation purposes, to give you an idea of how some of the conversations went. So very much how people met, how it was telling others about the relationship. Even that posed barriers for some couples initially. There was resistance to them having a relationship. This is obviously very much in a UK context, where it's more common that people are in relationships or marriages. I appreciate it's not always the same in all parts of Europe, talking about what they like to do, but also how dementia was broached with them, how was it explained to them, and how their life had changed, and how it may change in the future and the kind of support they were looking for. So these were, as I say, not all questions for everybody and not all discussion points for everybody, but also some of the images people like to use their own photographs. So we weren't completely, we have to use these, or we used expressions. So we had a choice of images. But these were ones we commissioned that, and we spent a lot of time, the advisory group, we have people with intellectual disability on our advisory group, as well as representatives from Alzheimer Scotland and key support services in Scotland. We wanted the images to be, so it wasn't clear who had dementia, it wasn't clear what the age, it wasn't even clear the gender, the gender of the people, because we didn't want to assume it was male female. We could have 2 males, 2 females here. So any relationship, I wanted to talk to people to find their experiences. I've just got one example on the screen here. One example. I won't read it out in full, but this is a long-term relationship that Anne, who had dementia, moved to a care home towards the end of her life, and her partner Ian visited, and their musical playlist. As we've heard so often of people with dementia, the musical playlist became really important. And this quote is from a staff member who was supporting them. So it was songs that they'd had at the wedding, songs they liked to sing together, that they were just literally in the moment, in that bubble, just a love story, like anybody else. But not all of the stories that we heard were positive. We had some not so. So we had another partner who moved to a care home just at the start of COVID, no visitors. So he actually died a year after moving into the care home, and his partner with intellectual disability had not been able to visit him at all. So we had real variation in the stories that we heard. But what we did hear was that lives were ordinary, like other people's, but they were different as well. So their lives were not private. The lives of the couple were not private even before a diagnosis of dementia. There were other support services in there. And a plus side of that is that it did mean that there was support already there, should it be needed, after the diagnosis. But relationships were very much located within the context of other people. There was still that power imbalance that was there as well. But both partners very active and contributing. Just to finish up, as with all the other studies that we've done, dissemination will be planned for a range of different audiences, including, of course, people with intellectual disability, so that when someone else finds himself in the same situation as Andrew, there is something, and there is somewhere to go, and there is a resource and support that is available. So I've put the QR code there on the screen. That's for more information about the project and the blogs that we've been writing as we've been going along. Thank you.
So, thank you, Karen. 2 questions for you. 2 quite difficult questions, but I'm sure you can handle it. So, yes, I remember reading this abstract, thinking it was wonderful, what you have done. And also, well, it's a small sample size that you have worked with. And if we were to generalize your study, let's say, take your concept and move it to Stockholm, Sweden, and implement it there, what are your top tips for that?
So we certainly wouldn't generalise from the findings of such a small sample size. What we're very keen to do is just to start the evidence, to start some knowledge and some awareness, provide some resources in the topic. But if the study itself were to be moved, then I think we were certainly impacted by COVID to a certain extent in terms of how we could collect data and whether we travelled or not at that particular time. But I think it helped looking and actually working alongside social care or third sector NGO organisations who introduced us to couples who were in that situation, and they talked to the couples before we did, quite rightly so, to say, look, the study is happening, would you be interested to talk about your experiences? So that was really helpful.
To use, so to say, the patient organisations as a tool, that is good.
Yeah.
And the other question, because, in Alzheimer's research or dementia research, it's often the person living with dementia or Alzheimer's and the caregiver. Could you elaborate a little bit about that? You said something about power structure between the couple here and the caregivers.
Yeah.
Just a few words.
Yeah.
What are your
In some
opinion?
instances, what the couple wanted for the future of their relationship was not always the same as their family member thought either might be in their best interests or was something that would... they weren't necessarily in agreement, and sometimes it wasn't so easy for the couple to actually to do what they wanted to do in terms of... And actually some of that went way back to the start. There was some resistance to couples getting married, not all, but some, and some resistance even to relationships starting. So it's different in terms of relationships between couples who don't have ID. There was different barriers to overcome in addition to dementia.
Thank you, Karen. We will have you back in a couple of minutes again. So.
Sorry.
Thank you. So now we shift perspective again from inclusion to detection. And this is Annalisa and Dominic. And you will also put a twist to digitalization, I hope.
Exactly.
That's interesting. Please go on.
Yeah, thank you, Karen. Good afternoon. My name is Annalisa, and today with my colleague Dominic Pendel, we are going to present our project, which we're carrying on in Austria at the University of Graz. And as you can see from the title, it's about the development of a digital tool for the early detection and documentation of dementia symptoms in people with intellectual disabilities. We come actually from the Institute for the Educational Research and Inclusive Education unit, but we got passionate on the topic, and now we are glad we can research on the topic and also meet some experts on the field. The project is called DigiD, and it's because of digital tool, intellectual disability, and dementia, and it is financed from the Chamber of Labor of Styria in Austria. And just a couple of words, I will connect a lot with what Professor Janicki already told, to frame a little bit the problem we would like to address with our digital solution. And that's it. Of course, we are glad and we are celebrating that people with intellectual disability are now reaching higher age, living longer, but this is new, specifically in Austria, where some historical legacy had to be overcome because before people with intellectual disabilities could reach older ages. And people with intellectual disabilities, and especially with Down syndrome, also have some genetic vulnerability to premature aging, which brings, of course, to an enhanced risk for suffering of age-related illnesses and especially dementia. Linked with that are some intrinsic difficulties with the diagnosis of dementia. That is, for example, the overshadowing effect. That is, sometimes symptoms of dementia are not being recognized because of the pre-existing cognitive deficit in people with intellectual disabilities, and that's why they could be overlooked. And neuropsychological tests to diagnose dementia are not suitable for people with intellectual disabilities. We could have some problems with floor effects, and there are no normative data, and so they are actually not usable. And other instruments, such as questionnaires filled in by formal caregivers, are not always reliable because they rely on the capability of observe the symptoms in a person. So that brings, we also have a lack of diagnostic guidelines that we hope we can overcome in the future. And so linked to those diagnostic challenges, we also have some peculiarity of the life of people with intellectual disabilities. That is that their family is also aging, and they sometimes need to move in care facilities where there's a high turnover of the staff. So formal caregiver don't always know the person so well and their history and their capabilities they had in the past, so we have a loss of personal information. That's why we'd like to address this problem, because the problem is that those factors bring to the reduced possibility of making an early diagnosis of dementia, which can bring some problems like not providing a suitable care, a worse prognosis, and an increased caregiver burden when the symptoms of dementia are not explained like symptoms of dementia. That's why we'd like to design a digital tool to address this problem that should facilitate the longitudinal observation of the behavior and capabilities of people with intellectual disabilities living without the family, so in care facilities, but also standardize the observation from caregivers of their behavior and like emotional responses in time, so focusing on the areas in which the first symptoms of dementia usually occurs in this population, but also to collect and maintain personal information as long as possible for people living without the family. And this solution should be user-friendly because we know that workers in social care facilities always could lack time, so we want to help them and not to give them other burdens. And we would like that the tool should not require diagnostic knowledge, so should not be used by psychologists or neuropsychologists, but from nurses and people working in care facilities. And it should be adaptable to the baseline level of each person with AD. So it should be actually designed on the person, and so that we see which capabilities and abilities he had or she had before eventually some decline or changes occurs. I would like to show you the timeline of our project. We started in March 2021, and we will continue with this finances till March 2023. And we will briefly explain you some of the stages we already did till now.
So yeah, as my colleague said, we would take a look at a few of things we did. First, I wanted to take a look on interviews we did. We performed interviews with 30 formal caregivers working with people with intellectual disabilities. Some data about them, which was really interesting. Like they had a working experience with people with dementia of 6.27 years, and 16 former caregivers have some specific training on dementia, but not on dementia and intellectual disabilities. So there is also a lack of trainings in this field. Yeah. What we did, we conducted interviews between September and October 2021. Then there was like a COVID break, and we started again in January. We transcripted and coded the different interviews, and some of the results which are important for our tool are like the first symptoms of dementia. So we asked the formal caregivers which are like first symptoms they can see in people with ID, and we brought like a word cloud for you, and the bigger the words are, the more often formal caregivers stated that this is like a first symptom of dementia they have detected in people with AD. So as we can see, and we also heard, like there is aggression and all these, I would say these behavioral changes in people with AD and not like cognitive things. Before we did like a little literature research, and together with the results from the interviews and the literature research, we held a workshop with formal caregivers who are like experts in the field of intellectual disabilities and dementia. And the aim of the workshop was to evaluate existing instruments that are used in Austria, and we just take a closer look on the important and the observability of the items that that they include. We used 3 different instruments. You can see it was the NDG EDSD, the DSQ IID, and the DTIM. We choose them because they, like I said before, they have been used in Austria and they are translated in German. And the last one is also, the first 2 are like tools where formal caregivers have to answer some questions, and the last one is also with performing like little cognitive things. Yeah, results from that. Caregivers stated that it's useful, and you should assess the different things of behavior of people with AD. They said that such tests allow like to take a closer look on the behavior, like it's not always in the everyday life. The different areas are all over considered as significant, but there have been some critical points. Some of the instruments do not use like an inclusive language. That was some things the caregivers stated. Like the problem was sometimes there were no clear instructions for like a baseline or follow-up assessment. We had some caregivers who are working with people with intellectual disability and dementia that are like communicate through sign language, so that is also not represent in that field. And yeah, I have to go on a little bit faster so that I can tell you about the observational dimensions we conducted. So we have like 9 different categories which we want to take a closer look and which we are implementing in our tool. These are like the 9 categories. Yeah, and there have always been like some subcategories, and for example, I only will focus on this one. Like personal cares, we ask if they brush teeth, and then there is like the question, can a person brush his or her teeth independently, and if not, please describe, so that we can yeah, make more or less a baseline assessment. So yeah, I'm skipping that now because time is over. And to come to, so yeah, we asked, I would say the last one. What we do now is like the last phase, we are now in the technical conception, so it's in progress. We want to do it like mobile first and give some more features like on the computer. And this is like the phase we are now into, and we are now yeah, writing a new application to get more funding and to get the tool into the institutions. So yeah, thank you for your attention.
So thank you, Annalisa and Janicki. And 2 questions, one from the audience online. So what do you say? Is there potential for using biomarkers in diagnosing Alzheimer's in persons with Down syndrome? For instance, blood-based biomarkers. What is your opinion?
I would say that is like a big field which is researched all over the world, I would say. But in Austria, it's like, yeah, to get a diagnosis for dementia in people with intellectual disability is not a common thing, I would say. Like in our interviews, most of the formal caregivers stated that, yeah, there is like a dementia, but it's not detected or like assessed in any clinic because no neuropsychologists or anything uses like some instruments to detect dementia. So.
Okay, good. So one question from me. I was thinking, Annalisa, when you went through your slides, that and when developing this tool, you want it to be for persons without diagnostic experience. I mean, it's a good intention, and in a dream world, I think that's what we want. We want nurses to be able to discern symptoms of dementia from persons with Down syndrome, for example. But how long will that take, do you think, until that is put to practice? Let's say that your tool would be developed, and how long will it take until we see it go live, do you think?
So we are trying to implement it as soon as possible, and that's why we're really working together with some institutions. We have a lot of big institutions for care in Austria that are collaborating with us. That's why, because we would like it to be used as soon as possible, and we have seen that this is really a need for people working in this area, because there's no more support from doctors or psychologists. So we are really trying to make a product that is targeted for them, and it can be used as soon as possible, because it should really be simple. So it should be really just a collection of information and like a guidance for which areas in which behavior should be paid attention to, and it should not be anything too complicated for these reasons. So that's, I mean, we will have like a prototype of the instrument maybe in a couple of months, and then we will pilot it with the institution, inside the institution. So hopefully. So
I wish you the best of luck. We will follow this carefully. Okay, so thank you, and welcome back, Karen, from detection to inclusion again, and now moving into the care home facility. Interesting.
Thank you, Karen. And yes, I'm sorry, it's me again. Apologies. I am presenting on behalf of Lynn Flanagan today from Health Improvement Scotland, specifically the iHub, the Improvement Hub, which supports service improvement in health and social care in Scotland. And what we'd like to do today is to launch a new set of guidance for care home staff to support the staff during a transition into a care home by a person with intellectual disability and dementia. So although a lot of the presentation will focus on the perceptions and the voice of the person with intellectual disability, the guidance has been developed from a specified need coming from care home staff who actually felt that more information. I've put the QR code on here, but I've also included it on the last slide and the web link. So it's hot off the press, just launched and available today, and free. It's very important as well. It's free. So we've seen the stats. We've been hearing about this as the session's gone on today. We know of the increased risk. So I don't need to tell you that again, particularly, of course, for people with Down syndrome. And I'm thinking about care homes. If you think about it, if you think about the average age of onset for someone with Down syndrome is early 50s. And when you think about the average age of a care home resident in the UK, it's considerably older. So that's a big difference in age gap. And this is one of the reasons why staff are struggling and wondering, should there be something different? Should there be extra? What are we doing that we're not? How can we get it right? Is the commendable starting point, I think, from this. And of course, I'm talking about a UK context in which a care home is certainly accommodation. It can be nursing care, personal care, social activities, community engagement, but all care homes in the UK are regulated, in Scotland regulated by the Care Inspectorate, who, along with Health Improvement Scotland, actually set about starting this work to make things better for within the care homes. But our starting point actually wasn't the care home. It wasn't the care home staff. It was the very last point on this slide here, where is home? Because we were really clear that this isn't about encouraging or suggesting that people should move to a care home. This was about making sure we could provide support for wherever the person called home for as long as that was appropriate. And often that's not a care home, or it's not a care home for a very long time. So our starting point is actually the person with intellectual disability and advancing dementia should be supported to stay in the home of their choice for as long as possible and practical. And that any move that is made isn't about budgets. It isn't because there is a bed available. It isn't service driven. So I'll talk about some of the reasons why moves might happen. But that was our starting point. Wasn't that, this is about moving people to care homes, because it wasn't. It was very much about supporting people. But we know that with or without intellectual disability, we see more moves to a care home at an advanced stage of dementia, quite often in a crisis situation. And we're seeing this in people with intellectual disability and dementia as well. So how can we make that, smooth that transition so that the move is as positive as it can be for everybody? So our starting point was that home isn't not an automatic assumption, that home is a care home. And as I say, this came from a particular area of Scotland, Inverclyde, who identified these issues in practice. And it's something that I hear echoed around Scotland, around the UK, beyond the UK, that care home staff are reporting that lack of confidence, lack of knowledge, lack of skills to support someone with intellectual disability, just not that understanding of what might be the same, what might be different, and why, and what can we do about it. And how far does their previous training in dementia meet the needs of persons with intellectual disability? So all care home staff in Scotland have mandatory dementia training. It's a requirement. Everyone has dementia training. And we have a system in Scotland called Promoting Excellence Framework that is at different levels of training. So depending on the extent of support provided for people with dementia, there's a corresponding level on the framework of training that's expected. None of those levels include intellectual disability and dementia in their training. So there's generic dementia training, but there's this perception of a gap. There is a gap, but there's also this, it's being perceived and look, we need to do something about this. And that's the question around whether the individual fit in. That's more related to the age that I talked about. And people with intellectual disability might have different forms of communication even before they have dementia. And this puts a fear in staff that there's something somehow different in terms of communication. And sometimes it's a fear that doesn't need to be there because it isn't any different. But without that knowledge and that awareness, this was causing challenges. So I'll just run through who was involved in the guidance, what the underpinning principles were, and the key themes that we've included. So on each of the slides, I've also included some quotes, and they are quotes from the guide itself. So we talked to a range of people, collaborated with a range of people, and including obviously people with intellectual disability. And what we've done is we've presented not one person's voice, but collectively we're presenting that voice, but as a personal outcomes approach. So we're looking at pulling together what people have said, and we're presenting that as quotes within the guidance. And I've got a few of them on the slides. And as I say, it's launched today. So here we are. My new home is supporting people with intellectual or learning disability and advanced dementia moving into a care home. These are the partners who were involved, and really important that it wasn't just care home staff, that actually we need to understand the lives of individuals with intellectual disability, and to do that we need to know their story. We need to know who's providing support and working alongside the person before a move, during a move, and after a move, and for that consistency throughout, for that transition period. So a number of partner organisations, and of course collaborating also with people with an intellectual disability, carers, including family carers, and of course care home staff, and those health and social care staff who were involved throughout the process, and not just after the diagnosis of dementia, not just as dementia progresses, and not just as a move is going to be made. So it's to make those links stronger. And of course, dementia's as unique to people with intellectual disability as it is to everybody else. And what our underpinning principles included was that personal outcomes approach, so looking at what people wanted for themselves. But in Scotland, we very much have a human rights focus on dementia, so someone having the right to decide where to live. And that means being involved in discussions perhaps earlier, rather than waiting to get to that crisis situation. So we have that understanding of what a care home is to start with. I've certainly worked with a number of people with intellectual disability who have grown up in some of the larger institutions, the long-stay hospitals, that congregate type environment. And in their head, this is also a congregate type environment. So actually, how do we talk about that in a way that explains the differences to perhaps what somebody's past experiences might be, and to actually what the future may hold in a completely different type of residential environment. So to really think about how we communicate and talk about the future. So I won't read through all the quotes, but a plan to support transition, ideally, and that staff know and understand routines, preferences, and wishes. So I mentioned promoting excellence framework, and we have drawn on that, so there's a lot of familiarity for staff who've completed dementia training already, but what we're doing is we're trying to fill those gaps in terms of what might be the same or what might be different for someone with an intellectual disability when they have advanced dementia. We also did a learning needs analysis with care home staff, and for us that meant finding out, really drilling down into more specifics, not just that staff were saying we need more training on learning disability, but what is it in particular? And some of the things we expected to hear, so some of the things like communication, like how do we know the individual? So they're things we could certainly build into the guidance with resources, strategies, tips, but also there was a much more fundamental level than that. There was actually, what's a learning disability? What different types of learning disability are there? So we kind of hadn't really thought of, we were thinking up here of some of the things that we might find in the analysis, but actually we were down here, we were quite basic level, that staff were saying, I need to know about learning disability before I can actually understand how best to support people. So that was certainly made us think differently in terms of the content. So the key themes, that I won't go through all these in turn, but the key themes are consistent with the Promoting Excellence framework, with the training that staff are familiar with already. And these will be very familiar to you in the field of dementia care anyway. So we're looking at what might be different, what might be the same. And just one example here of a couple of some of the strategies we suggest in terms of familiarity, so that things about the room perhaps that can help that transition. Sometimes it's not helpful to have an overnight stay or to go and visit or spend time in advance. Sometimes it's having that more familiar environment. But the crucial last sentence or two here, I would like a choice about where I live and who I live with. Ask me. Again, very familiar content on this slide here. What we were able to bring into the guide is things that might be different. So yes, we know about things like the importance of the multidisciplinary approach. We know about designing the environment, the importance of contrast, the aging eye, things that are more when to be calming, when to be stimulating. We know this kind of information. But actually, when we're talking about someone who has Down syndrome, they're typically not very tall. So actually, a lot of the chairs are going to cause pain because someone's feet can't touch the floor. So we just encourage thinking slightly differently about some things that staff might already know, but just thinking slightly differently about how they may provide that support and key things that might actually help someone to settle into a new home. Just to finish up with another quote here, I'll go to the last one. Last sentence, my care home must balance what's important for me with what's important to me. And that consistent message was coming throughout. So the link to the guidance and the QR code then again, as I say, free to use. Please do download it and use it and let us know what you think of it. And thanks very much. And I hope I've managed to do justice to the Care Inspectorate and Health Improvement Scotland. Thank you.
Thank you, Karen. Yes, you did. It was a substantial presentation that you finished very well. And I have a question, kind of broad question and difficult one, but I'm sure you can answer it from the audience online. Here it comes. Which countries in Europe are leading in diagnosing and support people with Down syndrome and Alzheimer's disease? And secondly, is there a collaborating network? What do you say?
So, which countries are leading? This is a difficult one. I think we're still in a situation in some parts of Europe where the life expectancy for people with intellectual disability is not as long as it is, it's not as high as it is in perhaps the UK, certain parts of Europe, North America, Australia. So we're seeing differences in the where people live, in the supports that are available, and in the screening and assessment for dementia, as well as post-diagnostic support. So I'm not going to name countries, Sorry if I'm not answering the question.
Maybe Matthew would like to say a
I
country.
was just going to refer the speaker or the person who asked the question to the T29RS group out of Barcelona. They basically are leading a coalition of various researchers across Europe and around the world, in fact, in research in Down syndrome. So if you want to know more about what's happening in Europe, that's the group to go to.
Yeah, thank you. That was a good tip. Yeah, and thank you, Karen, for elaborating on it all. I have also a question watching this presentation, being happy to see that the Scottish government has been involved, or at least as a supporting part. What are their expectations on this work, and what do you think they will do with the results here? Will they implement something positive for inclusion?
Well, they've certainly been very involved in this particular guidance, and we're at the stage of planning in Scotland for the next dementia strategy. So, of course, we would hope to see more practical suggestions and more recognition of the increasing needs of people with intellectual disability and dementia in future dementia strategies as well.
I hope so too. That will be a good example for the rest of the European countries. Let's hope you are the
I think
front runner.
I think hopefully we can move beyond just recognising that there is a link between intellectual disability and dementia. You know, we kind of know that. I think we need to move beyond that now in terms of the dementia strategies.
Thank you so much. And thank you to all the speakers. And since we have, well, a few more minutes, I'm opening up the floor for more questions, if there is some, or comments, or discussion, whatever you want. We have at least 5 minutes to go.
I have a question of the audience.
Yeah.
What kind of diagnostic impediments have you running into in terms of trying to access or source individuals or clinicians to give you information about the person, whether they have some kind of a diagnostic neuropathology or it's something else?
That question was too hard, Matthew. Please elaborate. Yeah. Okay, yes, please.
Hi, I was going to say, thank you so much for that presentation, and also that's a great question. I work for the Scottish Government in dementia policy, so I'd like to connect up with you and get your details so I can. I've had the privilege of I printed off the report. I was going to read it on the plane, but instead I read a book. But I will certainly go back and read that report and also take it back to the team and discuss it. One main challenge I face in terms of at the moment there is a gap looking at Down syndrome, and I was in the process of setting up a lived experience panel for dementia policy to inform the new strategy, and that gap, I'm struggling to address that gap at the moment. So I'm going to different organisations, mainly our third sector partners, to see if I can get a lived experience voice on there. We have plenty of perspectives and voice from professionals and clinicians, but that direct lived experience voice is key, and yeah, that's something that I'm struggling
I can help with that.
Yeah, definitely. Yeah, that's just a comment.
But you're absolutely right. It is difficult. It is difficult when people are in
I
that.
also want to do it in like a non-tokenistic way.
Yeah.
So glad that you were here. Yes.
Me too.
Yeah. No. Okay.
Sorry, I had a quick question. My name's Angie. I'm from Alzheimer Europe. I was wondering about the role of family, so not necessarily people who see themselves as caregivers or carers, but family and close friends. What is their role in supporting diagnosis for people with intellectual disabilities, and how can we reach them?
I think that friends can have a really big role to play. Often people with intellectual disability will live with others, who have an intellectual disability, and that's a choice as well. That's through choice, which is another reason why a move can be difficult, because often that's very long-term friendships. But certainly, friends can play a key role in actually helping determine how long a person may actually stay in that environment. Can have a real provided there's some understanding of what's happening, and why the person with dementia is experiencing changes, even if the word dementia is not used, because it will depend on how that has been explained to the person themselves, sort of from a sort of ethical point of view. But friends, certainly. It's very unusual, and I find this a lot, that it would be very unusual to come across a group of people adults with intellectual disability who haven't known somebody with dementia. It would be very unusual. So there is that awareness there, which adds to the fear of, well, will I get it as well? So I think it's about supporting not just the person with dementia, but others with an intellectual disability as well, who are in that strong position to provide support and help, but also have those fears themselves too. Anybody else?
Actually, sorry, Annalisa, if I'm interrupting you now, but we have one last question also from the audience online. I would like to take that, since I have Alzheimer Europe in the room. So the audience online would like to know that how can organizations like Alzheimer Europe support your work?
Well, they already are.
Yes, I'm so glad to hear that. So
yeah, and the session on intellectual disability today was incredibly welcomed, and also we had the opportunity to hold a session yesterday that just invited roundtable discussion.
One last question also crept up here, but that will be the last one, unfortunately, because we're out of time. But here it comes. Are you able to get dementia on the agenda of ID organizations? How can you do that?
We've not had problems getting dementia on the agenda, ID organizations. In fact, we get constant requests for presentations. In the States, we've been running webinars and training sessions around the country and workshops on this topic for agencies, so their staff are much more aware and prepared. So that's not been the problem. The problem has been integrating other organizations, peripheral organizations, in terms of getting them interested in ID as relates to their particular condition or thing that they're working on. That's always a challenge, and I suppose that's a challenge for any condition that tries to get broader attention. Yeah. But in terms of getting ID, dementia on the agenda for ID agencies, in the States, it's not a problem.
Okay, so yes, Dominic.
Maybe I can say in Austria it's like a little bit different, because the awareness for dementia in people with AD is not really there. So we have to start there to get to the point where like UK or the US is. So we're starting, I would say.
Okay, good. Well, this was a lovely meeting. So maybe this was a good start, continuation of already good work. And so I thank you all for coming here, and also the audience online, and especially the presenters. Thank you so much. Keep up.